Let's talk about HSV-1 encephalitis. So herpes simplex virus type 1 causes a treatable virus encephalitis. It can occur at any age, so you'll always have to be on the lookout. And the main modes of transmission include viral reactivation of a latent infection, or there can be a primary oropharyngeal HSV-1 infection that causes direct CNS invasion through the trigeminal or olfactory pathways. Defects in the toll-like receptor 3 pathway can predispose to infection, especially in children. And the most commonly affected site is the temporal lobe, and there will be a hemorrhagic necrosis. The clinical features are important because it's what determines starting treatment before a diagnosis even comes back. So the onset will occur over hours to a day or multiple days. There will be likely at least 2 of the following symptoms, including fever, impaired consciousness, headache, focal neurologic deficits, and new onset seizures. Once you suspect the disease, then lumbar puncture will be the main diagnostic workup, and it will show elevated lymphocytes up to 400 cells per microliter, elevated protein, and elevated erythrocytes. Remember, this is a hemorrhagic process. Glucose is typically not very low. So the CSF can be normal early in the disease, so repeat lumbar puncture could be helpful in cases where it's initially normal but you still strongly suspect the disease. Whenever you're sending off CSF, the gold standard for diagnosis will include a HSV DNA polymerase chain reaction, and that's going to be positive with a sensitivity of 98% and a specificity of 99%. If someone has had HSV-1 encephalitis already in the past, then it will be useful to send anti-NMDA receptor antibodies, as there is an association with prior HSV-1 encephalitis and future NMDA receptor encephalitis. Other tools in the diagnostic workup that's usually sent around the same time includes an MRI brain. This is much more sensitive and specific than a CT head, and there will be unilateral temporal lobe hyperintensities on the DWI and T2 sequences, as can be seen here. Most patients will also have an abnormal EEG, which is sometimes something that can show up on tests. There will be focal slowing over the involved area, and sometimes there can be periodic lateralized epileptiform discharges, as seen with these red arrows. So treatment will be initiated just based on clinical suspicion alone before any test results come back, and it typically includes meningitis and encephalitis coverage. Encephalitis coverage meaning IV acyclovir. Once the diagnosis comes back and it's positive for HSV-1 encephalitis, then you'll continue the acyclovir for 2 to 3 weeks. If other things such as imaging is negative and EEG is negative and the PCR is also negative, you can go ahead and discontinue the acyclovir, and you don't have to give it for 2 to 3 weeks. The acyclovir will reduce mortality by half, and it also improves later functional status, so it is important to start it as soon as you suspect the diagnosis. If acyclovir is not available, then ganciclovir can be given, but it is not equivalent in terms of treatment efficacy. For prognosis, even with early treatment, about a quarter of patients will die, and most patients, about 2 out of 3 patients, will have long-term sequela, which can include epilepsy, difficulty with cognition, and memory impairment.